Today we're going to see a couple of presentations on the unfinished agenda of maternal malnutrition and its impacts on birth outcomes. My name is Saskia Ozendarp and I'm the Executive Director of the Micronutrient Forum, who is hosting the Healthy Mothers, Healthy Babies Consortium, who's organizing this session for you. In today's session, we would like to increase your awareness and understanding of the relationship between maternal malnutrition, or undernutrition in particular, and adverse birth outcomes. We would also like to share the evidence on the impact of maternal nutrition interventions that are ready to scale up, and in particular of an intervention called multiple micronutrient supplementation, or MMS, and its impacts on birth outcomes. And we would like to share country experiences related to the integration of MMS in antenatal care services. So what do we know about maternal malnutrition and birth outcomes? Well, we know that maternal malnutrition is widespread and it has been neglected for too long. And in the last couple of decades, we have virtually seen no progress in the prevalence of maternal undernutrition worldwide. This has led to globally more than 240 million women of reproductive age in low and middle income countries that are underweight, about 630 million women that are anemic, and an estimated 450 million women that are stunted, which is a sign of chronic undernutrition. Despite this lack of attention, this year we have seen an increased level of attention and commitments to maternal malnutrition in the build-up for two important summits. One is the UN Food Systems Summit that has been taken place in September, and the other one is the Nutrition for Growth Summit that will take place in December in Japan. So what are the consequences of maternal malnutrition? Well, it does not only affect the health of the mother, but also of the unborn child. And it has implications and adverse effects on maternal morbidity, maternal mortality, and on poor pregnancy and birth outcomes. And as a result, 1 in 7 babies worldwide, or more than 20 million babies, are being born with a low birth weight, putting them at a disadvantage from the very start. While 20% of all stunting, this is a low height for age, and 30% of all wasting, this is acute malnutrition in children under the age of 5 years, is associated with them being born small for gestational age. And there are multiple interventions to improve nutrition during pregnancy in mothers. But in this session, we would like to focus on one solution called multiple micronutrient supplementation, or MMS, which is a solution to achieve micronutrient requirements that cannot be met in contexts where diets are being poor. And this is an intervention with a strong evidence base that is ready to scale up, that has been proven to be safe, efficacious, cost-effective, and affordable, as we will see in the presentations in this session. We know that MMS can improve micronutrient intakes, it can prevent maternal anemia, and it can reduce adverse pregnancy outcomes, and particularly so in settings where dietary quality is poor, where micronutrient deficiencies are common, and where anemia and low birth weight are public health problems, which is the case in many low and middle income countries. So in this session, we will first hear about the evidence on maternal nutrition and on multiple micronutrient supplements by Dr. Parul Christian, who is the director of the Human Nutrition Program and an associate chair of the Department of International Health at the Bloomberg School of Public Health at Johns Hopkins University. This will be followed by a presentation on the experiences in Bangladesh with MMS policies and programs by Dr. Mustafizur Rahman, who is the line director of the Directorate General of Health Services of the Ministry of Health and Family Welfare in Bangladesh. We will then hear about implementation research to enhance the introduction and effectiveness of MMS in 4 countries by Dr. Nita Dalmia, who is a maternal nutrition specialist at Unicef headquarters in New York. And finally, we will hear about policies and practices related to nutrition quality in antenatal care by Dr. Amy Pollack, who is the Director, Maternal, Newborn and Child Health at the Bill and Melinda Gates Foundation. Thank you.
Greetings, my name is Parul Christian, and I'm delighted to be presenting today on the topic of multiple micronutrient supplementation during pregnancy in the context of low and middle income countries. I will be summarizing the evidence that has been generated in the past 2 decades for this intervention in improving birth outcomes. Here is my disclosure slide, and I have no relationships to declare. So let's begin first by looking at the estimated global burden of low birth weight, defined as weight less than 2.5 kilogram. This figure shows that about 20 million babies were born low birth weight in 2015. The burden is highest in Southern Asia, shown in blue, contributing to almost half of the global burden. And as you can see, there has been a very slow decline in the prevalence of low birth weight from 2000 to 2015. Reduction of low birth weight, as you know, is also one of the World Health Assembly nutrition targets. Low birth weight babies are at a high risk of mortality, but also experience growth faltering in the first few months of life and need appropriate support to thrive and grow. The 2 main underlying biologic causes of low birth weight are small for gestational age and preterm birth. Being born too small or small for gestation age is one of the causes. Over 23 million babies are born too small and experience high neonatal mortality. About 15 million babies are born preterm, that is less than 37 weeks gestation, and 1.1 million die annually due to complications of preterm birth. Shown in red here are the various maternal undernutrition and other non-nutritional factors giving rise to low birth weight and its underlying causes. These include short stature, low pre-pregnancy BMI, low weight gain during pregnancy, and micronutrient deficiencies, among other factors such as adolescent pregnancy, infections, and lifestyle factors. So recently, global progress in the nutritional status of women and children was examined in the Lancet Nutrition series published earlier this year, in which I participated. And here I'm showing a couple of figures from the first paper. The graph on the left shows the prevalence rates of 3 indicators of maternal undernutrition: maternal low BMI, short height, and anemia in 2000 and in 2015. As you see, low BMI among women of reproductive age, one of the major risk factors of low birth weight and fetal growth restriction, has decreased from 2000 to 2015. But reductions in short stature and anemia are small. Shown in the right is a map of a subnational data on the prevalence of low BMI using smaller geographic units within countries. We found numerous subnational hotspots for low BMI in South Asia and Sub-Saharan Africa, showing that while national rates may have improved, there still exist disparities within countries. In this graph are shown regional estimates of micronutrient deficiencies and anemia in women of reproductive age. Data are derived from 52 national and regional surveys published between 2013 and 2017. Missing bars means no data were found for that micronutrient in that specific region. Also note that the black circles that are shown are data that are not representative. That is, only 3 or less countries contributed to the data. Overall, there are scant data on biochemical markers of micronutrient deficiency, particularly in Africa. High prevalence of deficiencies, as you can see, are recorded for vitamins B12, vitamin D, iodine, zinc, folate, and iron in low and middle income country settings. These data are on micronutrient deficiency prevalence for different vitamins and minerals in early pregnancy from one study in Nepal, suggesting that women are deficient in multiple, not single nutrients, given the chronically poor diets. Few such data, though, exist on micronutrient deficiencies in pregnancy from different countries, and we need more data in this area. So with that background on maternal nutrition and micronutrient status, I would like to share with you a brief history on the trajectory of the evidence generation that occurred for antenatal multiple micronutrient supplementation in the context of low and middle income countries. It is well recognized that there is a high burden of low birth weight and that women enter pregnancy with multiple, not single, micronutrient deficiencies. In high-income countries, it is common for women to use a one-a-day supplement. Thus, in 1998, the United Nations International Multiple Micronutrient Preparation for Pregnancy, a multivitamin mineral supplement, was designed for women in low middle-income countries by the WHO and Unicef. Following these, there was a need and a call for generating evidence related to the efficacy of this intervention using randomized controlled trials to examine the impact on birth outcomes in these populations. Here is the composition of the Unimap formulation. It contains 15 vitamins and minerals at an approximate RDA for pregnancy, according to the US Institute of Medicine in 1998 requirements with some modifications. Some of the details of that are found in that report that I have provided. Now, fast forward to today. Almost 15 years of research went into generating the evidence for antenatal multiple micronutrient supplementation. 17 trials were conducted across Asia, Africa, and Latin America. Multiple micronutrient supplements were compared in these trials against a standard of care control of iron and folic acid. The Unimap formulation was used in many trials, but not all. And birth weight and low birth weight was the primary outcome in a majority of these trials. A recent Cochrane systematic review was completed, which actually included a total of 141,000 women in the trials, and there were a total of 19 trials. Another stratified individual participant data analysis was also undertaken, including 17 trials and almost 113,000 women. And I will present and summarize the results from both of these analyses. So here are the main results shown both for the IPD analysis and the most recent Cochrane meta-analysis. Multiple micronutrient supplementation was compared to the standard of care for iron and folic acid. There's a high quality evidence to show that it reduces the risk of low birth weight by 12 to 14%. The confidence intervals are quite tight around this estimate. And there is also moderate quality of evidence that there is a slight reduction in preterm birth by 5 to 7% and a reduction in small for gestational age by 8% in the Cochrane analysis and a small 3% reduction in the IPD analysis. Also, this is also significant. While there was no overall reduction in neonatal mortality, although I must say that only a few trials were powered to examine mortality as an outcome, there was some evidence of mortality reduction in subgroups. Here you see that multiple micronutrient supplementation reduced the risk of mortality among female infants in the neonatal period and throughout the first year of life, a benefit that was not observed in male infants. The p-values are those for interactions, which were significant. One important consideration is whether multiple micronutrient supplementation is at least as good as iron and folic acid in impacting hemoglobin and reducing anemia during pregnancy, given that iron and folic acid is recommended for antenatal use in many countries where the burden of maternal anemia is high. This is the meta-analysis looking at MMS versus IFA on anemia. As you can see, there is no difference between IFA and MMS. The relative risk is close to 1, indicating that multiple micronutrient supplements are just as good as iron and folic acid in impacting the risk of anemia during pregnancy. Let's look at the guidelines related to MMS. In 2016, when the WHO antenatal care guidelines were released, MMS was not recommended for pregnant women. Subsequently, several guidelines were revisited and updated based on new evidence and further deliberations. In 2020, WHO updated their guidelines to include MMS in the context of rigorous research, especially calling for a need for implementation research in this area. In summary, there is clear, rigorous, and consistent evidence that antenatal multiple micronutrient supplementation is a superior strategy and intervention than iron and folic acid. It reduces low birth weight, small for gestational age, and preterm birth. It also contains iron and folic acid that is recommended by WHO. I did not present this, but it is also a cost-effective intervention, and there are papers looking at this that are published. Implementation research is needed to design programs to deliver MMS in the context of antenatal care and other platforms. Many policy and programmatic questions remain, including the need for a financing model and the production and procurement of the UNIMAP formulation, and adoption of policies by countries. Adoption of policy to replace iron and folic acid and MMS is urgently needed in LMIC contexts where maternal micronutrient deficiencies are widespread. Thank you.
It is a pleasure to be here today at the FIGO World Congress. I am Dr. S. Mustafizur Rahman, Line Director, National Nutrition Services under Ministry of Health and Family Welfare. Greetings from Bangladesh. Thanks to the FIGO organizer for inviting me. I am honored to share the progress of the Bangladesh as forerunner of the maternal nutrition as well as the multiple macronutrient supplementation for healthy mothers and healthy babies. We all know multiple macronutrients are essential for the mother during pregnancy as well as the positive birth outcome. Bangladesh government is really working on this issue, especially under the Ministry of the Health and Family Welfare. We are working through the National Nutrition Services. We have developed a maternal nutrition guide, and in this guideline we are strictly following quality of the service provider through the training, and we also maintain the supply chain as well as we try to improve the awareness of the mother as well as the community people so that they can support this service without the initiative of the government always. So what are the service available there? Service available there are very important need-based macronutrient supplementation, need-based training, and the awareness creation of the community. The major policies and strategies in Bangladesh you will find from the independent who are serious about the macronutrient issues and the maternal nutrition. The Constitution, which was started in the 1972, supported the maternal nutrition as well as the nutrition issue, and this is the responsibility of the country. Over the 4-5 decades, we have developed different policies and strategies, just like food and nutrition policy in 1997, national nutrition policy in 2015, as well as the National Plan of Action for the Nutrition 2017. And if we see, we can see the national strategy for the adolescent in 2017 to 2030 all are in place, and we are working with those. And if we need any strategy or policy in future, we will do that one to implement the maternal nutrition related issues and the new research findings. So this is really a very congenial environment for the policies and the strategies to handle, to overcome all the nutrition related issues. Bangladesh government always try to practice the PPP. The public-private partnership is in practice in Bangladesh. In this issue, we also use the same modality. In addition, we have also national strategy on prevention and control of the micronutrient deficiency 2025 strategy. In recent times, in last 1 decade, we have done two national micronutrient survey. One in 2011 and 12, one in 2018 and 19. In both the survey, we have seen the deficiency of the vitamins and minerals are still there, which is really alarming and needs special intervention to overcome the study findings. To combat micronutrient deficiency among pregnant and lactating mothers, we have formed technical advisory group on maternal nutrition and MMS with diversified stakeholders. I am leading as the chair of the track, and this track includes the technical advisory group is formed with the representative from the public and private sector, development partner, civil societies, and the academia. Bangladesh is the first country from LIMC that is producing MMS using Unicef formulation. We like to share our progress of our approach towards maternal nutrition and the MMS with other countries like Ethiopia. So we hope to work together with FIGO and others to take the agenda forward. Thank you all.
Hello, it's a pleasure to be here today at the FIGO World Congress. I'm Nita Dalmia, and I'm the Global Lead for Maternal Nutrition at Unicef. I'd like to start by thanking FIGO for organizing this event and for inviting Unicef to share its approach towards introducing multiple micronutrient supplements in 4 countries in Asia and Africa. In this presentation, I'll cover Unicef's vision to improve maternal nutrition, followed by an overview of our approach to introduce multiple micronutrient supplements as part of implementation research, and finally present some of the early lessons learned from supporting implementation research in these 4 countries. Unicef's Nutrition Strategy 2020-2030 is an opportunity to intensify efforts to improve maternal nutrition. Important gains have been made over the last 2 decades to reduce the prevalence of stunting in children. However, gains in women's nutrition have been mixed. Underweight has declined amongst women in low and middle income countries, but other metrics of women's nutrition, such as anemia, low birth weight, overweight, have fallen short of what is needed to achieve the Sustainable Development Goals. Further, in the era of COVID-19, the need to secure the food and nutrition rights of women has never been greater. The nutrition strategy emphasizes the need to improve the diets, access to services, and caring practices so that all women realize their rights to adequate nutrition. The strategy emphasizes the potential of different systems, that is, the harnessing of different systems, such as the food, health, and social protection systems to deliver nutrition results for women. UNICEF and the Bill and Melinda Gates Foundation have entered a partnership to introduce multiple micronutrients as part of implementation research in 4 countries in Asia and Africa. This partnership aims to establish proof of concept for successful MMS introduction in Bangladesh, Burkina Faso, Madagascar, and Tanzania. And in these 4 countries, MMS is being delivered as part of antenatal care, along with nutrition counseling and weight gain monitoring. The introduction of MMS in these countries provides an opportunity to improve the quality of pregnancy care for all women, similar to what is enjoyed by women in industrialized countries where MMS is the standard of care. So what is implementation research and why does it matter? Implementation research is a form of practical research which aims to get what works to the people who need it the most with greater speed, fidelity, efficiency, quality, and finally relevant coverage. In short, implementation research can help pregnant women benefit from improved maternal nutrition services, including multiple micronutrient supplements. Its relevance in this context is that all 4 countries face systems-related challenges in achieving high coverage of antenatal care and iron and folic acid supplements. The chart on the right shows that there are huge missed opportunities in ensuring that all women receive pregnancy care. Antenatal care contacts cover only around half of all pregnant women, and coverage of iron and folic acid supplements with 90+ tablets ranges between 10 to 50% in these 4 countries. So Unicef has conducted analysis of delivery systems, supply chains, formative research, and the results across the 4 countries show that they all have weak service delivery platforms which affect women's ability to access routine antenatal care. And this is reflected in the way that antenatal care services are organized, distance and financial barriers such as transportation and the cost of supplements, all of which prevent women from accessing services. Finally, healthcare workers are not adequately trained to counsel women on nutritious diets and supplements. On the supply side, countries report weak supply chains and frequent stockouts of iron and folic acid supplements. Formative research conducted in these countries shows that ANC is not designed with women's needs in mind, and this affects coverage and adherence. And further, women face a range of cultural norms around food and misconceptions around iron supplementation. Their capacity to access services, nutritious diets is greatly influenced by close family members and gendered norms. So as part of the implementation research, a number of strategies have been identified to support improved antenatal care and the introduction of multiple micronutrient supplements. And these include expanding the antenatal care services. To illustrate, one of the strategies identified in Burkina Faso is to expand the number of days when antenatal care is offered to women from 1 to 3 days a week. In Bangladesh, Unicef is exploring a strategy to bring antenatal care closer to where women are working in garment factories. Another strategy is to strengthen the links between facilities and communities and bring antenatal care and multiple micronutrient supplements closer to where women are in the communities. And so all 4 countries are planning to task shift responsibilities to community health workers to promote early antenatal attendance and MMS adherence. And Madagascar is going one step further. In one district, they're going to explore whether community health workers can be effective in actually distributing MMS. And in Tanzania, the government is looking into whether switching to free MMS distribution will help to remove some of the barriers to uptake. Implementation research also offers the opportunity for innovation. And in this case, Unicef is supporting innovation with product design. Based on the formative research findings, Unicef has taken women's feedback on their preferences and worked with MMS suppliers to improve the packaging, and will explore how this results in improved uptake of MMS. And here on the right of the slide, you can see an image of the improved package. So valuable lessons are emerging from these countries. What have we learned so far? Implementation research must be country-led. All 4 countries have established national technical advisory groups to ensure national ownership of the process and results, and some have even included local research institutions as part of the process. That implementation research should respond to the country context and be designed to achieve scale. And finally, some of these learnings are already informing the design of implementation research in other countries and also fostering South-South learning. And so with this, I'd like to thank you for your attention.
Hello, it's a pleasure to be here today at the FIGO World Congress. My name is Amy Pollack, and I'm the Senior Director for Maternal, Newborn, and Child Health, Family Planning, and Nutrition at the Bill and Melinda Gates Foundation. I want to thank the FIGO organizers for making this event possible, and I'm honored to share my thoughts on the critical role that nutrition plays in improving the well-being of mothers and children. Our approach to maternal health at the Gates Foundation has evolved significantly over the last few years. We have now integrated maternal nutrition within our MNCH strategy to accelerate thinking and implementation of the highest impact solutions. Maternal nutrition is the underlying cause of 1 in 5 maternal deaths, with anemia as the leading cause of maternal deaths, most often due to obstetric hemorrhage postpartum. Maternal malnutrition increases the risks of stillbirths, perinatal mortality, low birth weight, preterm birth, and congenital anomalies such as neural tube defects. Maternal anemia is associated with altered and delayed pre- and postnatal neurogenesis and myelination and impaired intellectual development. Today, I'll be focused primarily on the importance of integrating maternal nutrition in health services, but it's critical that we also consider how to reach women before they become pregnant, as I will explain. Women often enter pregnancy with nutrient deficiencies, and in addition, access ANC services too late and too infrequently for interventions to realize their full potential. Anemic women enter pregnancy with inadequate iron stores to support the increased demand for iron required to develop the fetus and the placenta in the context of pregnancy-related expanded maternal blood volume. Many women, particularly in low and middle income countries, start taking iron and folic acid supplements when their pregnancy is first socially recognized, but a first ANC visit is most commonly in low resource settings at 16 weeks, and this is too late to avoid many adverse outcomes. Starting pregnancy with adequate iron and folate stores can make a big difference. Folic acid supplementation around the time of conception significantly reduces the incidence of neural tube defects, but when it begins after the first trimester of pregnancy, it's too late for prevention. Addressing anemia and other nutrient deficiencies before pregnancy makes the biggest overall impact for several reasons, including the establishment of habits that need to continue throughout the pregnancy for full impact. Strong health systems and communities are absolutely essential. If OBGYNs, midwives, nurses, and community health workers aren't factoring maternal nutrition into their antenatal care, it probably means that maternal nutrition interventions aren't getting delivered. You've heard from other speakers today about the benefits of multiple micronutrient supplements, or MMS. Designed specifically for pregnant women, it's a cost-effective and proven intervention that can impact maternal health and birth outcomes for mothers and babies everywhere beyond just iron and folic acid supplementation. In Bangladesh, for example, it's estimated that replacing iron folic acid supplements with MMS could avert over 7,600 deaths resulting from stillbirths and infant mortality, and 16,000 cases of preterm birth annually. So I'd like to focus on a few policies and practices that need to be put in place to effectively deliver maternal nutrition interventions through the health system. First, at the top, Ministries of Health and their directorates at national and subnational levels are critical to setting national health policy. This can ensure maternal nutrition interventions like MMS are owned and delivered in the health system. Better antenatal care platforms to deliver maternal nutrition interventions are critical. For example, our partner Alive and Thrive, in partnership with the government of Bangladesh and BRAC, integrated maternal nutrition interventions in ANC platforms. The interventions included counseling on healthy eating, including dietary diversity and food quantity, daily oral iron and folic acid supplementation and calcium supplementation, weight measurement, and breastfeeding promotion and support. In a period of just 3 years, the results were pretty astounding. The average number of IFA tablets consumed during pregnancy increased from 45 to 139 tablets. The average number of calcium tablets consumed during pregnancy increased from 60 to 145 tablets. Weight measurement increased from 38% to 98%, making malnutrition an early indication of the need for an intervention, as noted by weight measurement, and exclusive breastfeeding practices increased by 30 percentage points overall to 78% of mothers. Bangladesh is now in the process of transitioning from IFA to MMS, but the key is that they figured out the systems level changes that are needed to make these kinds of interventions work. The question is how? The answer is that activities both within and beyond the health system helped healthcare providers deliver more and higher quality nutrition support, including helping influencers surrounding the mothers, including fathers and community leaders, play a more active role and supportive role throughout their pregnancies. For healthcare providers, improved timeliness and quality of ANC contacts were encouraged through targeted interventions such as feasible caseload allocation, home visits used to deliver ANC, thereby reducing logistics and transportation needs, were another intervention. This work will look different from one country to the next, but the common thread is that healthcare providers can't possibly deliver high-quality nutrition interventions if they aren't supported to do so. Alive and Thrive has developed a framework for implementing maternal nutrition programs at scale, which includes 4 key programmatic components: interpersonal communication and community mobilization to improve awareness, confidence, and skills of both pre-pregnant and pregnant women; advocacy for supportive policies at the national, district, and sub-district levels that raise the priority of maternal nutrition; mass communication to reinforce messages for mothers and frontline workers and to involve families and social influencers through public awareness; and lastly, strategic use of data to track the progress of intervention delivery and impact on coverage and practice. We need to make nutrition supplements a social norm throughout a woman's life. But there are other platforms that can be leveraged in addition to this to increase the coverage and impact of maternal nutrition interventions. In Pakistan, we're testing the effectiveness of delivering balanced energy protein supplements, also called BEP, through a national social protection program providing support exclusively and intentionally to women. Among undernourished women, BEP supplements during pregnancy have been shown to increase the weight of babies at birth, decrease stillbirths, and decrease the risk of small for gestational age babies. Finally, I know we all share an acute urgency to introduce and scale maternal nutrition interventions. The COVID-19 pandemic has put the most vulnerable even at greater risk. Without adequate action and within and outside the health system, the profound impact of COVID-19 pandemic on maternal and early life nutrition could have intergenerational consequences for child growth and development, and lifelong impacts on education, chronic disease risks, and overall human capital formation. I look forward to hearing and learning from my fellow presenters and to continuing to partner with many of you to make our vision a reality, that healthy mothers can deliver healthy babies who thrive into childhood and beyond. Thank you for your time.
In this session, we have heard about the relationship between maternal undernutrition and birth outcomes. This session has also laid out the evidence base on MMS, which is as effective in reducing maternal anemia as iron folic acid supplementation, but is more effective in supporting good pregnancy outcomes. MMS is safe, It's affordable and it's highly cost effective. We know and we've learned that countries are learning lessons now on implementing MMS as an integrated aspect of antenatal care, as well as through private sector delivery mechanisms. We know that MMS can serve actually as an entry point to strengthen the quality of nutrition interventions and antenatal care services. We know that the WHO last year in their updated guidelines on antenatal care recommend the use of MMS for context-specific research. Now, what does this mean? This means that MMS can be used in the context of antenatal care services, informed by implementation research and designed to optimize MMS introduction, and that clinical research needs to be continued as part of a global agenda to inform future WHO guidelines as they are updated. In addition, last year, Unicef and ENN issued a guidance on maternal nutrition programs in the context of the COVID-19 pandemic, where they recommend the introduction of multiple micronutrient supplements, or MMS, in settings with a high prevalence of nutritional deficiencies or where food supplies are significantly disrupted. So with this, I would like to close the session, and I would like to thank all the speakers, and I would like to thank you for your attention. I would also like to invite you to contact the Healthy Mothers, Healthy Babies Consortium, which is a consortium of cross-sectoral stakeholders that are active in multiple micronutrient supplementation programs or research globally and at country level. I would like to invite you to contact the consortium or visit the website for more information about maternal nutrition and about MMS, or to consider joining us or share information that you may have on maternal nutrition and MMS at the Knowledge Hub that's also available on the site where you see the link here. Thank you very much for your attention. Bye.